Good evening, dear colleagues from all the world. To me, it's a huge honor to be here with you. I want to say thank you to Professor Samuel Morsi, who invited me to participate in this beautiful and amazing webinar. My name is Arturo Ayala Arcipreste from Mexico City. I want to share this lecture with you, and the lecture is titled like a transiliar approach to cellular anterior floor lesions. It's very important to say that 100 years ago, Dr. Halstead said, I believe that the tendency will always be in the direction of exercising greater care and refinement in operating. Well, this technique have a evolution, and this year, 1971, Professor Donald Wilson published this article about limited exposures in cerebral surgery. Like 11 years after, Dr. John Jane from Virginia, designed the supraorbital approach in this article, and is one of the most important originals about the transiliary approach. Dr. Al-Mefti described in 1985 super or lateral orbital exposure reconstruction to the approach to skull-base 2. But the most famous and important professor that impulsed this kind of approaches is Professor Axel Pernesky from Germany, and all we know the books about he published about keyhole approach in neurosurgery, and many articles about the concept of keyhole in the neurosurgery. In Mexico, Dr. Rafael Mendizábal and other professors start in 1997 with this resection of cysticercs in the optochiasmatic cistern in the patient who have some optical defects due to this infection. And obviously, we need to know about the anatomical aspects for the surgical plan, and the anterior floor have sometimes many difficulties. Obviously, we try to avoid this kind of frontal sinus, and we need to study very well all the eminence and all the endofrontal characteristic of the anterior floor. We need to know, obviously, that every patient have several characteristics and distinct from each other persons. And in the end, we try to reach these areas and try to dissect lesions and try to remove all the tumors or any kind of lesions in this area. Like we can see in this slide, we can see the central part of the anterior floor, and this is one of the most benefits of this approach. Then the frontal eminence of the cribriform plate or some endofrontal areas is important to analyze in the studies because have many different forms. Like Professor Yassihil said, we need to understand all the arachnoidal wall, all the cisterns beside or inside of this area, because we need and we try to dissect very carefully every neurovascular segments of these elements. Like we know, the anterior floor and cellular tumors, the most of them are meningiomas in the anterior floor, or in the cellular region, adenomas, pituitary adenomas, or craniophryngiomas. But sometimes other kind of tumors, other kind of lesions with another biology could be possible invade this area. We know the many approach to anterior floor and sella. One of the most important arterial, the ZOZ, orbital frontal, transversal, obviously endoscopic. We use endoscopic the most of the time with kind of tumors. But in this time, I will talk about the transillary approach or the eyebrow approach. This beautiful article about the comparison of mini craniotomies or with the other approaches are very important with Dr. Mario Zuccarello, mentioning with this drawing everything. We can see the areas, angles, and triangles that we can obtain with this terminal approach, with transillary approach, or the cranio-orbital approach with a huge extensions, very flexible. But we can see in the slides what the three are focused in the center, in the optic apparatus, and obviously the major vessels here. This technique have some advantage. We have a small craniotomy, but we have a very wide angle of action. Obviously, the structures we need to dissect very carefully, and we need to make a space evacuating the CSF to try to avoid brain retractions. And we can see structure ipsilateral and contralateral from this approach. This approach discovered a narrow surgical corridor, and we need to be very skilled with microinstruments, and we need to the support of endoscopic assistance if our microscope we have a limited visual control in some areas we need to put inside the endoscope. The surgical indications for this approach are cellular or paracellular tumors with a small diameter, less of 3.5 centimeters, or supracellular extensions not more of 30 millimeters over clinot. Cystic tumors are very easy to dissect, some CSF leaks, and some others neurosurgeons have a good window to put the clip in the anterior circulation aneurysms, obviously the most of the time unrupted. The head position, we have in the primary position of the head with a little bit of retroflexion and with a mild angulation. And we can see the skin incision here is in the middle of the eyebrow. Then we can use history here, and we can try to avoid touch the skin, and we can try to avoid the use of monopolar. We use the most of the time bipolar forceps to the coagulation. We can see in the bottom of the area we are over the bone now, and we can use the monopolar to resect the layer of the muscle here, and after of this point we can make the space with the rogier, and we can try to separate the periosteum of the bone and make enough space to make the approach. And in this point we dissect the temporal muscle in the lateral part of the orbit, and try to clear the muscle here, the temporal muscle, to put a burr here. This burr we can make with a little drill, and obviously we try to avoid perforate the dura mater. We can see the dura layer, and now with the lateral drill we can detect a small window like 2.5 or 3 centimeters. Then this is enough space for the tumor, the lesion that we can make. We can use the endoscopic assistance, but I want to show this pituitary adenoma. Can you see the most of the volume of the tumor is suprasellar, and this is a good selection for this approach. Then, if we have the small window here, we dissect the dura layer and we are drilling the endofrontal eminence of the anterior floor. Obviously, the objective is be flat in that direction. We need to drill because sometimes these eminences are very huge, are very high, and we can make a good dissection. We open the dura here, and we are at the level of the anterior floor, and we are trying to discover the arachnoid layer here. And in this point, we try to avoid the frontal lobe traction. Then we are evacuating the CSF, and in the bottom we can see the dura layer, sorry, the arachnoid layer, and in the middle we have this structure, the carotid here, and beside is the tumor. We can see very well the carotid here, and beside is the tumor. Well, we can open all the cisterns. We try to evacuate with this CSF, and we can see the optic nerve here with the compression for the tumor here. Well, at this point, now we have the same view, like a pterygium approach here. We can use the endoscope only for academic purpose, or could try to make a GPS inside of the neurosurgeon's head, the neurosurgeon's mind, and we can see the optic nerve, we can see the olfactory nerve here, and these kind of views, we try to make a good analysis of the area in the head of the neurosurgeon. Well, after of this, we can see the tumor here, the carotid here, and the optic nerve. Well, at this point, we can continue this resection of the tumor in the classic way. If you see, we open the capsule of the tumor, and we, with the curettes, we are removing, yes, and we can see, like in any other approach, we make the same resection. Okay, at the end, if we can see better the optic nerve, we can see the compression now, and this is the result after the surgery. Okay. Then let me see. This is the end of the surgery. Okay. This is another case. Yeah. This is a female of 57 with a visual scotoma and headache. And if you see, we can see a small meningioma in this part of the anterior floor. Is a little bit in the tendency to the left, is inclined here, and part of the tubercella is a small lesion, and these tumor are not too big, and we select this case for this approach too. We make the same, we open the skin, we make a space over the bone, we try to make enough space to avoid retraction of the skin, we make the burr hole here, we try to don't touch the nerve, the supraorbital nerve, and we make the small window with the Midas Rex, and at the end we open the window here, and you can see it's a small window. We take the measures, 2.5 centimeters, and after this we make the drill of the anterior floor. With the diamond drill, we can remove all the endofrontal eminence, open the dura now. We see the agnodal layer. This is in the bottom is the carotid. We enter with the endoscope only to try to see many angles of the tumor here. We can see the tumor now, and we try to dissect all the structures beside of the tumor, dissect the surface of the tumor. We can see the typical aspect of meningioma. Sometimes we use the navigation to be sure of things or for academic purpose. And we coagulate the base of the tumor to avoid some several bleeding. Then we can see the structure of the tumor, the structure of the typical meningioma in the surface. We use the aspirator, the ultrasonic aspirator, to make a little debulking inside to be more easy the dissection, and it's more easy the manipulation of the tumor. This is the surface. Look at this, the typical aspect of the meningioma, and we can see how is the vessels there, and really the major vessels like carotid, okay, and obviously in this point the anterior cerebral artery, and this is the implant of the side of the tumor, okay, between the clinot and the tubercella. Okay, in this point all the approaches is made, and the resection of this little meningioma is very easy. Well, this is the form that we dissect the tumor. The endoscopic view of the final of the is tumor implant. We can see all the structures here. And obviously, this at this time, we have 1 hour of surgery in this point. Okay, this is CAIAMS, one optic nerve, it's lateral. We make a little reconstruction with titanium mesh. Okay, well, sorry, this is the first case of the pituitary adenoma. This is the pre-op, this is the post-op. We have another case of the tubercular meningioma here, and it's in the same way. We drill the anterior floor. We can see the meningioma in this point. We dissect from the optic nerve from the both sides. We use the dissection very carefully and dissect the meningioma. This is the pre-op, this is the post-op. Well, this is the visual fields, the perimetry, and you can see pre-surgical and post-surgical 2 months later. Okay, another kind of lesion very frequent in some tropical areas is the cysticercs. The cysticercs are very cystic in some cases, and invade the cisterns, and one of the most is the optic cisterns and the suprachiasmatic cistern too. We make the same approach, and you can see we use the drill to try to flat the anterior floor. Okay. We can see the cysticerc is between the nerves, and if you see, we try to dissect. Sometimes the wall of the cysticerc are very thin, and usually sometimes the capsule is broken, and we need to wash with many solutions here. This is the cysticerc, and in the end, we try to see the optic apparatus, the optic nerve, and you can see the arachnoiditis here. Is sometimes these arachnoiditis have a very strong tissue, and in that moment you know why it's very important to dissect this kind of infections in the cisterns. The reconstruction is one of the points very important, because the most of the time, like the incision is in the eyebrow. The concern about the aesthetic is very important. We can make these kind of reconstructions. Sometimes we don't have the same metal material, but the most of the time titanium mesh. And in the end, we have the aspect of these patients. This patient in the center have a tattoo here, and if you see, the aesthetic result is very acceptable. Well, in this time we have 93 cases with this technique. Obviously, all the most of the time the cellular tumors are removed with endoscopic now, but in the pandemic era we use transiliar, trying to avoid the respiratory tracts in the pandemic time. This is the most of the time we make this for pituitary adenomas, the most of the time with supracellular extension, craniopharyngiomas, meningiomas, 2 epidermoid cysts, 1 hemangiopericytoma, and 60 cells. You can see this is the outcome. The most of the time we made the total resection, but sometimes we make subtotal. The most of the time is because some tumor residual in the bottom of the cell. Yeah. The most of the craniopharyngiomas was cystic component, and this is the others tumors. The complications above subsidence in 5, transitory diabetes in 6, frontal numbness, meningitis, and you can see this is the only one that have an abscess here because of the manipulation. Well, the conclusion of this, the transcellular approach is very useful. It's a good surgical option for lesions in the cellular region and anterior floor, with the adequate criteria, size, and intracranial conditions to avoid complications. The anatomic knowledge and the training through narrow spaces is mandatory. The endoscopic assistance is useful tool for these microscopic angles of visions. Well, I hope that these lecture are useful for the colleagues in the world. And thanks so much. And I want to say again, thank you to Dr. Samuel Morsi. And this is a huge honor to me be with you. Thank you so much. I stop now. Now I'm going to the lecture in the Latin American Congress. Is at the same time, at the time of this lecture. That is why I record this lecture, because now is in the same time I will go to make a lectures in the Congress. Thank you so much.